Over to you, Dr. Fairooz.
Thank you, Rolika. So, well, it's always been a pleasure and honor to be part of such a nice instruction course. And, well, we're all tumor lovers over here. And tumor means tumor of the eyelid, the ocular surface. And I think ocular surface tumors are more important as far as a conference like AIOC is concerned, because it covers a whole spectrum which would be useful for a specialist in ocular oncology, anterior segment, surgeons, as well as a general ophthalmologist. And that's exactly what the vision of this particular instruction course is. And I'm going to take you through the tumors of ocular surface, epithelial and stromal tumors. These are my affiliations and these are my financial disclosures. So, well, tumors comes in different colors, they comes in different shapes. Well, conjunctival tumors, to be honest, it's not too difficult to diagnose because every tumor comes with a clue in the color. Every tumor comes in the clue of the shade and the location in the ocular surface. And it's obviously one of the cancers of the eye that is readily visible for your naked eye. You just need to pick up what is important to differentiate between a benign and a malignant lesion. So the objective of my talk here today is clinical diagnosis and differentiating features, where management will be covered by Dr. Honavar. Now, going on to the classification, as I'm going to deal with epithelial tumors and stromal tumors, well, epithelial tumors again are classified as non-melanocytic and melanocytic. I'm not going to touch upon melanocytic because Dr. Vikas Menon is going to give you an extensive talk on that. Stromal tumors can be vascular, it can be fibrous, depending upon, where it arises from anatomically, histiocytic, myogenic, lipomatous, and lymphoproliferative. Then we have a very important location in the eye, which is caruncle, which has got all the structures. You can have squamous epithelium, you have sebaceous glands, you have hair follicles, and there are particular tumors, although rare, arises from the caruncle. Metastasis, secondary tumors, and congenital tumors. We did publish about tumors of ocular surface a large review, and well, it is available in IGO. When we talk about ocular tumors, what is very important as a practicing clinician is to differentiate between benign and malignant. Well, we are concerned about malignant. We want to reduce the recurrence and we want an excellent outcome for these patients as far as vision salvage, eye salvage, and life salvage is concerned. So I'll take you through few cases which will give us an overview. It's totally case-based. Certain cases which I learned, and I'm going to share my experience with you. Now, very basic, we know that benign and malignant, there are certain characteristic features which differentiates each. Age of onset, progression, whether it's recent or long-standing. For example, if it's a recent, rapidly progressive lesion, be it in any part of the body, it probably is a malignancy. Symptoms, location, surface, vascularity. Now, vascularity and feeder vessels, I would combine it together, and that actually is the biggest clue in differentiating a benign from a malignant lesion, because we all know for a tumor to grow to its size rapidly, it needs oxygen. For oxygen, it needs blood, and for blood, it needs these large vessels, and these are called the feeder vessels. Well, I want to keep it as an interactive, but Rolika is doing an interactive down there, but just tell me like which one do you think is a malignant lesion here? You have one in your left and your right. At least tell me how many out of the 6. 3 is malignant. Perfect. Can you tell me which one, right or left? This one? This is what? Malignant? Perfect. This one? Malignant? Perfect. This one? Yeah? Plus or minus, yeah. And what you see here is the fierce redness in them, right? It's completely vascular. There is large feeder vessels. And that's how you differentiate between both. In fact, yeah, this is a cyst, this is a pterygium, and this is a myocystic over here. All right? We'll come to the other diagnosis in subsequent slides. Well, easy, 72-year-old gentleman, gradually progressive mass, 1 year. In fact, he had previous surgeries done multiple times. He was referred query lymphoma to me. Well, it looks fleshy, It really looks fleshy. There is surface vessels over there. It's arising from the fornix. But this particular test of a transillumination gives away that it is a cyst. So it was an inclusion cyst with a history. So history is also very important, that he has undergone multiple conjunctival ocular surface reconstructive surgeries in the past, and it's from that he developed an inclusion cyst. Now, here this lady presenting with a lesion in a left eye in the temporal bulbar conjunctiva, in a right eye temporal bulbar conjunctiva. Let me show you. Yeah. So this is what she has. This is cystic indeed, right? She doesn't have a history of surgery. She says it has been present there since childhood. This is slightly cystic, but more of fleshy, right? Asymmetric, both eyes. And she says, well, it has been there since a long time. If anyone can shout out the diagnosis, I'll be very happy. Otherwise, I'll proceed. Shifali, you're not telling the answer. Yeah, does it look like a cyst, like an inclusion cyst? What can be that conjunctival lesion with some amount of scattered pigmentation, childhood, which can be cystic? Yeah, Shruti? Nevus, right? Yeah. So this is, well, all nevus has microcyst, some has macrocyst, and some has balloon cyst. Okay, so this is basically a balloon cystic nevus of this eye, and well, nevus need not be always melanocytic. I'm sure Dr. Vikas is going to take you through a lot of pigmented lesions. So if they have some amount of scattered pigmentation, we have something called a amelanotic nevus. We also have something called amelanotic melanoma of the conjunctiva. So all nevus need not be, but well, you know, the cyst, the microcyst and the macrocyst in a pigmented lesion or query, scattered pigmented lesion always gives away as a conjunctival nevus. This was a very interesting case. This was a Chinese patient of mine, young girl, 32-year-old, who was diagnosed as chemosis, like, you know, long-standing chemosis, punctures done, still it's not going away. It's transparent, right? And it's compressible. Cysts are usually not compressible. It's like, you know, tenons. Underneath it's pretty tight. So this is the lesion there. Pretty rare. So, well, it was during that time that a series of this particular tumor was published, and I thought probably it could be that and excised it, and it's a conjunctival stromal tumor. It's called coast, something which is very similar in terms of a coast which is transparent and, you know, fleshy inside is myxoma. So conjunctival myxoma can be associated with cardiac myxoma. Well, there is no direct association of a coast to cardiac myxoma, but well, you know, when a patient comes with coast, we still evaluate them cardiologically with a cardiologist in order to rule out a cardiac myxoma. Very straightforward case, 2-year-old child, spot in the eye since birth. It is limbal dermoid. All right, yeah. Now, 32-year-old lady, eyelid swelling and fleshy mass, both eyes, childhood that she says. You can see some amount of fullness in the upper eyelid laterally, looking like a lacrimal gland swelling. Lower eyelid, more fullness in the other eye, taking you through. So this is what she has, all right? This fleshy lesion over here, fleshy lesion inferior, fleshy lesion in the other eye. What could it be? What do you see there? Here, some amount of dermal appendage. This is actually a hair which is coming out, okay, dermolipoma, right? So we have been taught in our textbook that most of the dermolipoma, all of the dermolipoma in our teaching, that it's in the superotemporal fornix, right? Need not. We always thought it's unilateral and unifocal, but it can be bilateral, it can be multifocal. What gives away is this particular yellowish color appearance. There is a hair, 2 hair coming out over there. There is a follicle over there, and this gives away the diagnosis. So this is a dermolipoma, multiple bilateral. All right, yeah. Well, straight away case. Yeah, reddish lesion. So anything which is red. So now we came from yellowish, whitish, Now we go on to the reddish, okay? Straightforward, this is a capillary hemangioma, right? You can have small capillary hemangiomas, you can have big capillary hemangiomas. Now what is this? It's again red in color, but it has also got violet in color. It's a shade of reddish color there. A little bit, nicer in between, and then comes another reddish layer. Venolymphatic malformation, Shruti, right, yeah. So this is the entire lesion, including the caruncle and then extending into the bulbar conjunctiva. So this is a venolymphatic malformation. Anything red, we always think of vascular, and most of the time we are right. All right, this is also venolymphatic malformation, an extensive venolymphatic malformation where it was an orbitoconjunctival venolymphatic malformation, even involving the frontal sinus, where initially she was actually operated by a neurosurgeon. All right, for the conjunctival. This is how patients reach different specialities where they really don't know that there is a specialty called ocular oncology who can deal with all tumors of the eye in and around. Well, and she had repeated, it was excised before. Well, we all know that venolymphatic malformation, how much ever you excise, it's gonna be there, right? Yeah. So, conjunctival orbital sinus venolymphatic malformation, this is the frontal sinus portion that I am showing with the arrow. The only thing that I did, I was not a magician. Patient thought I had like a magic hand, no, we all know what really works. You don't need to go and do an extensive surgery in this case. This is a magic drug. We are happy and blessed. And she has this ptosis because of the previous neurosurgery that was done in her, including the sinus. And this is all that was done, including the sinus, and she did well. She got married. Well, this is another case, again a reddish lesion, okay? We have the ISSVA classification of vascular tumors and vascular lesions. So I'm just showing you a spectrum of these reddish lesions. Well, any diagnosis over here? She has been operated twice before, and then it again balloons up elsewhere, and then they said that, can you do something? So anything? Is it venolymphatic malformation? Is it capillary hemangioma? Doesn't look like, right? It's like really purplish. Yeah, more of venous blood, right? Yeah. So this was a venous malformation. In fact, this patient had venous malformation which was connecting to the cavernous sinus. Well, after counseling the patient, I still went ahead with bleomycin. Yeah, I was careful because when I sent her to the neurointerventional radiologist, he told me if I have to clip those tiny extension into the cavernous sinus, she might require 75 to 100 clips, which is difficult. So then, I took a little bit of risk there, but it really worked, injecting it anterior, and bleomycin worked for her. Pyogenic granuloma, we all know, it is a misnomer. It can come from a scarring after your OSSN excision biopsy. With an AMG, you can have a pyogenic granuloma. It is a hyperproliferation of the tissue with vascularity, and this was the same. Conjunctival papilloma. So usually OSSN is the differential diagnosis of papilloma. OSSN arises from the limbal area. There will be some amount of limbal origin, but this is way away from the limbus, something like OSSN. Always think of conjunctival papilloma, and this patient was an immunosuppressed patient with HIV. 37-year-old, reddish lesion. She comes with recurrent subconjunctival hemorrhage in the left eye, past 2 months, up and down. There is no vascular lesion. Sometimes a venolymphatic malformation can bleed. It can be transparent, then it bleeds, But this was something very different. Yeah, it doesn't have any purplish look. It's some kind of a yellowish look, but there is a recurrent bleed. Anju knows the answer. Lymphangiectasia is one of the diagnoses, yes. Anything else? Awesome. So this was subconjunctival hemorrhage, and these are the things that we usually think of: venolymphatic malformation, amyloidosis, and the worst, Kaposi sarcoma. This was amyloidosis, and this was primary and localized. This one, now we come to the white. This was in fact referred to me, query case of sebaceous gland carcinoma. Sebaceous gland carcinoma cannot be white, it's usually yellow. So, well, since it was referred and I don't want to make a mistake, I said, well, you were going for an excision biopsy, just limit it, not the wide margin excision, and if something comes out, we will treat further. And this was a keratin cyst. All right, yeah. Yeah, same. Now, coming to a little bit of pinkish, yeah. stromal, extending from here all the way up here. Sorry? Louder? What is it? Benign reactive hyperplasia. Well, that usually is in the limbal area, you know, it's a differential diagnosis of an OSSN, yeah. Well, this is kind of very irregular surface, right? When you see something like this, a salmonish, the thing that you think of is a lymphoma, but lymphoma has that particular feeder vessels which comes from somewhere and just dips inside. There is a prominent vessel in lymphoma. It doesn't have that, right? This was also a case of primary local amyloidosis. So we have a big series now. I don't know how these things, I attract amyloidosis, I really don't know. We have a large series, I think we have been seeing one after the other every month. And this is a varied presentation of amyloidosis. And I think probably our eyes doesn't see what our mind doesn't know. And these are the presentation. This was just a small, you know, query SGC, concretion, and I just did a biopsy and this came out to be a amyloidosis, extensive. This was very, very extensive where the patient presented with ptosis. 50-year-old lady referred for a mass, both eye, recent onset. She had a fullness over here, query, fat prolapse. Well, it really doesn't look like a fat prolapse, right? Fat prolapse is yellowish. This is again salmonish, and you can find that feeder vessel, right? Dot on. The other eye also. So it was multiple muscles affected bilaterally. The only thing that I did, I just went and did along the muscle. In fact, yeah, I went for an imaging. This is the imaging over here where the muscle is involved. So ocular surface need not be only ocular surface stromal tumors. It can be a muscle, a lateral rectus or medial rectus where there is an infiltration with lymphoproliferative lesion which is involved. And yeah, I just did a biopsy along the, you know, muscle, not cutting it vertically but horizontally, and it came out to be a non-Hodgkin's lymphoma, extramarginal zone, low grade. This is how we evaluate them. Now, 56-year-old lady, you know, frequent redness, bilateral. She's been on and off steroids and on and off lubricant eye drops, and these are the lesions that she has. And this was also a case of Malt lymphoma. So lymphoma can be this tiny as well. That's now 70-year-old gentleman, whitish lesion, right eye. Can I take 2 minutes? 2 minutes, yeah. Right eye, 4 months, very classical keratin feeder vessels, right? Straightforward case, OSSN, and it arises from the limbus. Now, we have ocular surface squamous neoplasia as a spectrum, dysplasia, carcinoma in situ, squamous cell carcinoma. Well, we need to differentiate between them, and why is it important that OSSN in insequential pterygium specimen, it's reported as high as 10%, and OSSN coexistent with pterygium is almost 2%. So, well, you know, whenever there is a suspicion, it's good to send your pterygium specimen for histopathology. SCC is important because it's the most common conjunctival malignancy, and aggressive variants like mucoepidermoid, spindle cell, and adenocarcinoma is present. Clinical diagnosis is perilimbal location, keratin, rose Bengal staining, feeder vessels, intrinsic vessels, corneal encroachment, and scleral fixity. Scleral fixity, of course, you can do AIOS2025 stuff, but in the presence of keratin, it's very difficult because there will be a lot of backscattering. So this is a very simple test using a cotton bud, whether it is fixed or not. Now, risk factors, as you all know, xeroderma pigmentosum. This was a child presenting as early in her 7 years of age, papillon lephor, which is very, very rare, immunosuppression and UVB rays. This is a kind of a papillary OSSN, which simulates a papilloma, yeah, conjunctival papilloma. But then, well, this is a feeder vessel, which is very, very different from a papilloma. This definitely looks like a small nodule, very, very small nodule, but it's the aggressive variant of an SCC, squamous cell carcinoma of the conjunctiva, which is mucoepidermoid. Well, cornea, easy, we take AIOS-OCT, and this is a very classical presentation of a pouting of the epithelium and thickening of the epithelium that you get in a corneal OSSN. Diffuse corneal OSSN in an immunocompromised patient, which was in fact treated as, you know, various other corneal erosive disease, but it was a case of OSSN. Necrotizing scleritis is yet another presentation in advanced OSSN. It can be pigmented, known as pigmented OSSN, not a nevus, but you have this surface keratin over the pigmentation, which makes it a pigmented OSSN. Clinical documentation is very, very important. Before we take these patients in for surgery, we actually just not delineate the elevated nodular area, but also the congested thickening of the conjunctiva, and 4 millimeters from either side will be our excision. Ultrasound B scan for intraocular extension and orbital imaging in case of, orbital extension, especially if it is in the caruncle and the fornices. Caruncular tumors, quick takeover here. Oncocytoma, I just saw one case in my whole 12 years and 13 years of my practice. Very, very rare, but these are the lesions that you should be keeping in mind in the caruncular lesion. Sebaceous gland hyperplasia, 68-year-old gentleman, redness, fiery red lesion. It could be a sebaceous gland carcinoma as well. Sebaceous gland carcinoma can present as a very asymmetric unilateral blepharoconjunctivitis, which is a pagetoid intraepithelial variant of a sebaceous gland carcinoma. One last quiz. Is it OSSN? Is it amyloidosis? Is it venolymphatic proliferation, venolymphatic malformation? Is it vascular lesion? What could it be? No, Shifali, sorry. Sorry? Excellent. You win a prize. It is extensive rhinosporidiosis of the conjunctiva. It was referred, query malignancy to me, a young guy. And, well, I treated him with complete excision, AMG, and cryotherapy. Yeah, thank you so much, and it's been a pleasure. I hope it was useful, and well, it is a wide clinical spectrum. Clinical diagnosis is very important to get dot on to plan further management. Thank you very, very much.
Thank you so much, Dr. Fairooz. That was absolutely interesting. I do not think I need to give my